We are live.
Good evening and a very warm welcome to iFocus Online Lecture 519, the 10th in the series of eye and systemic diseases. Today we have Dr. Sudharshan Sridharan from Sankara Nethralaya, Chennai to speak to us about eye in HIV infections. He did his primary education from Karnataka and went on to do his fellowship in uveitis and ocular immunology from Sankara Nethralaya, Chennai. He's currently the senior consultant in the Department of Uveitis and the Digital Communications and Library Department. He is also a part of the Secretary of the Uveitis Society of India, the Associate Editor of Indian Journal of Ophthalmology, the co-guide and guide for postgraduate optometry, MPhil and PhD students. He's an investigator in the ICMR and other funded research projects. He's been awarded the AIOS IGO Gold Award for the paper Human Immunodeficiency Virus and Intraocular Inflammation in the era of highly active antiretroviral therapy. He's authored many peer-reviewed publications and chapters. He's a member of the International Uveitis Study Group and International Ocular Inflammation Society. His keen areas of interest are in uveitis entities and HIV-related eye diseases. Who other could speak a whole hour on HIV-related eye infections other than this, sir? Over to you, sir. I'll just stop sharing, sir, and you can share your slide.
Thank you. I thought the whole hour it was going to be introduction itself, like it is going on and on, like so. I thought, thank you. And so voice is okay, right?
Yes, sir.
So talking of HIV, like sometimes I keep wondering if it's still relevant nowadays with so many newer viruses and newer infections. But then, if at all you want to think of one systemic disease that has actually helped a lot of many other diseases, studying them, then probably HIV is one thing. So we'll see eye in HIV and overview of everything. So obviously it is almost like a boasting or a self-acknowledgement. That's what I keep telling whenever I show these publications, the gold medal winning review article, which you mentioned just now. And we probably have the highest number of study of ocular lesions in HIV in India.
Sir, sorry to interrupt. Can you just make it in slideshow mode, please? Yeah, now it's good. No, it's again.
It is in slideshow for me.
No, it's not for us, sir. It's not coming as slideshow. You can stop and reshare, please, and share the entire screen.
Is it okay?
No, sir. As of now, it is in a normal. This thing is not in slideshare mode. You can go on top and make. Yeah, same.
Is it okay now?
No, sir. Did you select the presentation or did you select the entire screen?
I selected the presentation.
No, don't select the presentation, sir. Select the entire screen. The first option, left-hand side top, entire screen.
Okay.
Still not happening. Dr. Ashwita, are you able to see? I'm not able to see.
No, actually, so you'll have to press that slide share option below on the right. Yeah, that the one on the right side next to the zoom button. Yes, so just please press on that.
It's pressed.
So, did you select the entire screen again or on the PPT? Can you just stop share for a minute? I'll just guide you.
Yeah.
Just click on the share button once. Don't go sharing. The pop-up comes.
Yeah.
On left-hand side top, there is an option called entire screen. Just click on it. Just select that.
This one?
The first option, left-hand side top, entire screen. It should say entire screen.
Yeah, that's what it is.
Then click the blue button, share. That's it. Yeah, perfect. Now it is good. Perfect.
That's fine. Okay. Sorry about it.
That's fine.
But okay, talking of HIV, 1,000 cases of HIV and so many things. But how did it all start? So it all started off first by Dr. Gottlieb. It seems they saw some 3 or 4 puzzling cases in some homosexual men. He and his colleagues reported 2 more of them in a morbidity and mortality weekly report. in CDC. This is probably one of the first publications. You can still see the screenshot of that. Like they've actually described how a previously healthy is the word, 33-year-old man developed pneumocystis carinii. He had CMV viruria. They didn't know there was a disease that is going to affect the next so many decades. So they reported this kind of vague disease of a pneumocystis pneumonia in healthy individuals, and that probably was the first publication of HIV. The causative virus, human immunodeficiency virus, was identified later, a couple of years later, in 1983. So when we keep talking about generation WX, probably this is a Gen X virus, because the Gen Z virus seems to be the COVID-19. All of us are more scared about COVID-19. But then HIV, they say no, like I keep remembering this statement by Sehwag once in cricket. Baap baap hota hai, like beta beta, like about Sachin Tendulkar when he was talking. So like HIV actually seen it and done it all types. When it is severe immunosuppression, you have endophthalmitis, panophthalmitis, infective retinitis, mucormycosis, and others. And when you have an altered response, inflammatory or immune-mediated response, you get immune recovery, newer immune-based diseases. You even get reactivation of old uveitic or other similar entities. You can have drug-associated uveitis and occlusive vasculitis. So COVID, we saw that all this happened, and HIV is actually seemed to be doing this many years ago. So looking at HIV history, the first epidemic, as I said, started off in 81. But then the first antiretroviral drug was released, the Zidovudin, in 87. So it took quite a number of years for people to identify identify a drug which will act against HIV. Then came the protease inhibitor, sacunovir and nevirapine and other things which are actually more potent. They decided that you need a combination drug therapy, highly active antiretroviral therapy in 1998. It actually revolutionized HIV treatment. So it decided how patients are going to live and how long they will be living. And the new ARTs, fusion inhibitors came into being later on. In 2010s and 15s and 20s, now we see that HIV has become a chronic disease. It's not that people are worried about about death due to HIV, but the side effects and quality of life in HIV. That is what we are going to see now. So HIV in 2025, the thinking, the management, some have remained the same, but there are quite a few changes too. Basic science research based on HIV has helped manage many infections and pandemics. So initially they used to have some age-defining illnesses like cytomegalovirus retinitis. CMV retinitis was one of the age-defining illness. And if you find anybody with CMV retinitis, then probably you know that you are probably dealing with a case of AIDS. If a patient has an extrapulmonary TB, you need to suspect HIV, a pneumocystis carinii pneumonia with choroiditis, or a PML, or an atypical toxoplasma. But then how does HIV work? The main target is the CD4 cell or the T cell. HIV tries to attach to the host cell, and the virus changes from the RNA to DNA. It integrates into the host cell's nucleus, multiplies into reproduces many viral components, gets assembled again, and then into the bloodstream. So this is something like a foolproof mechanism, like it's unmatched mechanism that has not taken over by any other virus. That's how it's been there, and it's still going to be there. So you know that you cannot kill it, but you can probably live with it. Initially, this was a famous picture when during my fellowship days. HIV disease used to be compared with an impending train wreck. So the viral load was compared to the speed of the train, and the CD4 count used to be compared to the distance from the site of crash. The more the viral load, the HIV load, the speed of the train is more. It means that the distance from the site of crash is going to be lesser. It means that the CD4 count of the patient is going to be much lesser. But then it's no longer like that now with newer ARTs. Now HIV, as I said, is a chronic illness, but still it can affect any organ and including eye. So it's very important for us to know that like what will happen in a patient with HIV even though the patient is on ART in the eye. The most important devastating ones are the infections. So when I was looking at the title, I was wondering like HIV in eye versus HIV associated eye disease. Sometimes both are not same actually. I think like probably eye in HIV means like it can be any other disease in a HIV positive patient. But those things which are due to HIV, which are attributable to HIV can be because of the opportunistic infections, because of the virus itself, because of the drugs that are used in the treatment of the virus, because of the immune recovery, and some things are not directly attributable to HIV. So let's start off with probably this is how, if somebody is wanting to write a theory answer for a HIV and eye lesion exam, this probably is the way you can classify it. Those due to attributable to HIV, not directly attributable to HIV, and others. The opportunistic infections are the most devastating ones. We'll start them off. The most scary ones are the posterior ones. Everybody knows about it. The most popular one is the CMV retinitis. CMV retinitis has two specific types, the hemorrhagic type and the granular type. The hemorrhagic type is something where you have significant fulminant retinitis with a lot of hemorrhages, and the granular type, you can have some powdery appearance, which looks like resolving type, but then you'll have to make sure that you don't miss out an active granular type of CMV. The hemorrhagic type occurs in much more lower CD4 counts, while the granular type are nowadays seen even in immunocompetent individuals. So, leave alone this CMV retinitis, any HIV patient, you will have to ask for history of CD4 counts at different stages. CD4 count at the time of diagnosis, CD4 count at the time of opportunistic infection, what is the CD4 count increase when ART was started and after how long, and there is something called nadir CD4 counts. The lowest point at which the lowest CD4 count at any time, any point in life for the patient. So it's very important to know the nadir counts, because when there is an increase in count, you'll know how much has been an increase, and that will be very important later on when we talk about immune recovery. So asking history of a patient, you ask CD4 counts at different stages, at presentation, at the time of opportunistic infections, nadir counts, what ART the patient is taking, and what is the combination, and when was it changed, whether the ART regimen is ART 1, 2, whether patient has had any resistance to it. The HIV load, this is what they check now, the peripheral viral load of the patient. CD4 counts are not the actual guidelines nowadays. Whenever resource constraints are there, then you start looking for CD4 counts. But if affordability is there, then viral load is the best way to monitor the disease in HIV. You may have moderate CD4 counts, but then if the viral load is less, then you still feel safe. You have to look for and ask for other history of other ocular or systemic opportunistic infections, and at-risk factors whether the patient has. So this is how you ask history in a patient of HIV. But then anyway, coming back, when you see a patient with CMV retinitis, the next step you do is like, how do you manage? CMV retinitis is an ocular manifestation of a systemic disease. So you treat them systemically. So ideal situation is IV ganciclovir, ideally. But then, like, considering the resource constraints, logistics, and practically, valganciclovir, which is a prodrug, is an equivalent option. The initial treatment is 900 milligram twice daily as an induction dose for about 2 to 3 weeks, followed by maintenance dose of 900 milligram once daily, and then you can taper based on the response. Intravitreal ganciclovir as a lone agent, as a solitary treatment therapy, is not a great option. It can be given in addition. It definitely helps. The antiviral drug is there inside the vitreous and helps treatment. So the main treatment is systemic IV ganciclovir or valganciclovir. Intravitreal ganciclovir can be additional therapy. Vitrasert is an implant, the ganciclovir implant. You have the second generation implant, which has a drug release for about 3 years, but I haven't seen one. We don't use it in India. So CD4 count, initially CMV retinitis was always thought of as a disease that can that usually comes when the CD4 counts are less than 50 or 100. But when the patient is on ART, you can still have CD4 counts about 200 or 300. You can still have CMV retinitis in moderate levels. So it means that this is how CMV retinitis occurs in non-HIV immunocompromised or in patients with malignancies or chemotherapy too. So it is not that they are immunocompromised fully. And you need to know the difference between the immunosuppression and the immunocompromise. It is not that they are immunosuppressed fully, but there is a compromise of their immunity. So a compromised immunity also can cause reactivation of these ubiquitous organisms. So one of them is CMV retinitis. So even with 300 plus CD4 counts, you can still have active CMV retinitis with inflammation. So when you have this kind of vitreous haze, see the difference between this picture and probably this picture. The clarity of the retinitis lesions in these pictures are so clear. It means that there is no vitreous haze. When there is vitreous haze, it means there is some immune response happening in the body. So an active CMV retinitis with inflammation means that the CD4 counts are much better. So you know that the patient's general systemic status is a little better. If you have a frosted branch angiitis like picture or an vasculitis, again it shows that there is an inflammatory response happening in the patient. His systemic status is better. So currently at this stage, most of the time you get patients with this kind of picture where there can be some immune response or inflammatory response if the patient is on ERT. If untreated, CMV retinitis can become very fulminant, can go into optic atrophy, can have retinal detachment. If it can have an exudative retinal detachment or a tractional or a recombinant retinal detachment based on multiple reasons. A retina can be lifted from the edge of the scar also. In pre-heart, the reg RD used to be much higher, about 30%. Every third person of CMV retinitis used to have RD. But in the heart era, it's only about 6% nowadays. One important thing for all the retina specialists who need to remember is that when you do surgery, you need to have a higher viscosity silicone oil tamponade. Sometimes immune recovery uveitis can also result in exuberant inflammation, PVR formation, and higher chance of recurrent RD. So what is IRU? Immune recovery uveitis. We'll look at it. So now in 2025, it is not about clinical diagnosis alone. It's all about imaging too. So when you can have a multimodal imaging, we actually have a talk I think in a couple of weeks on imaging in systemic diseases. Probably you'll be taught much more clearly by Anirudh. The autofluorescence and SSOCT are helpful imaging tools in CMV retinitis. The edge, where there is an hyperfluorescent edge, slowly starts resolving, and this is how it can pick up the healed lesions. Even if you don't see the active retinitis, you can see this edge, this one, and then it resolves. So you know that this is where you can monitor the treatment response in patients with CMV retinitis. So that was about CMV, the most popular probably among the posterior segment manifestations. But the next herpetic lesion is the VZV or HSV retinitis, the acute retinal necrosis or progressive outer retinal necrosis. I think we had a talk on viral infections by Padma, which was in detail about this. But one thing you need to remember in immunocompromised patients on HIV is the typical cracked mud appearance, which you see in HIV positive individuals. As students, you need to know the differences between acute retinal necrosis, progressive outer retinal necrosis, and CMVR. If the etiological agent according to Sun working group classification is either HSV or VZV, then you call it ERN. But if it is CMV, then you don't call it ERN, you call it CMV retinitis. So acute retinal necrosis is one where you have the classical presentation of a peripheral coalescing necrotizing retinitis. You have a triad of a coalescing necrotizing retinitis, a moderate to severe vitritis, and periarteritis and periphlebitis. This is Kansky, so it's nothing new. And the PORN, the old classical term, means they are more posterior, the retinitis spreading close to the disc. So if you have a hemorrhagic retinitis like this, I said it can be CMV retinitis. But then if you have something like a bleached out appearance, where you don't have too much of hemorrhages, if you have a granular appearance, I said it could be granular CMV. But one important differential diagnosis of a granular CMV retinitis is a toxoplasmic retinochoroiditis. A CMV retinitis can have a hemorrhagic type or a granular type, but if you have a less granular type, less hemorrhages with a vague Chiarelli's kind of arteritis. So if you have a if you have a retinitis with an arteritis like picture like this, then you need to think of some a subtle sign called a Chiarelli's arteriolitis, which can be seen in toxoplasma. We have a talk on parasitic diseases. Probably it will be in more detail about toxoplasma in that talk. But how is toxoplasma different in HIV? That's the second most common ocular opportunistic infection in HIV. One important thing is you don't have these pre-existing scars in HIV toxoplasma. Most of them are unifocal. It can be multifocal or necrotizing retinitis type. That's how you miss them as CMV sometimes. It's very important that a high positive predictive value is noted when you have high titers of antitoxin and IgG antibodies. It's always important to have an intraocular specimen evaluation, PCR maybe, antibodies for toxoplasma from the aqueous or vitreous, And there is something called Goldman-Whitmer coefficient, which you need to check for toxoplasmosis. 1/3 of the patients in those days of ocular toxoplasmosis used to have CNS involvement. So neuroimaging in those select cases were very important, and it used to be treated with pyrimethamine and sulfadiazine in those patients. Systemic treatment for toxoplasmosis is by a combination of pyrimethamine and sulfadiazine, but then you can augment it with intravitreal clindamycin. This is one patient where it doesn't fit into the typical headlight in the fog appearance of a toxoplasma, which you see in immunocompetent individuals. This toxoplasma in HIV can be extensive. It can mimic CMV. I'm repeating it again and again. So in this patient, it was diagnosed by ELISA and ACTAP, and with systemic antitoxic therapy, hard and intravitreal clindamycin, it resolved so well. So I was showing differences between CMV retinitis when you have less inflammation and more inflammation. So most of the time when you have no vitritis or less vitritis, then you're always thinking of a immunocompromised state. But if you have a retinitis with significant vitritis despite low CD4 counts, so if you have higher CD4 counts, you can have significant inflammation. But if you have low CD4 counts, you should have less inflammation. But if you have significant vitritis despite low CD4 counts, then you need to think of two differential diagnoses. So one is toxoplasmosis, another one is syphilis. Syphilis and toxoplasmosis are atypical retinitis where you can have significant vitritis despite low CD4 counts, and they can have atypical presentations which are very not so familiar patterns. So it is very important to suspect ocular syphilis in these patients. Initially, ocular syphilis used to be thought of as something that can come in primary syphilis, secondary syphilis, and tertiary, or each of them had a different publication based on that. But then now we realize, based on most of our studies from India, that it is definitely a greatest imitator, has definitely had a great comeback, and can occur in any stage of syphilis. Apart from the risk factors of ocular syphilis and HIV, which have common risk factors, primary syphilis itself facilitates HIV transmission. HIV may modify the natural course of syphilis by altering the immune response to treponema. It actually increases the propensity to neurosyphilis and ocular syphilis. So ocular syphilis has to be thought of as neurosyphilis. The treatment is also similar to that. You need to treat them with crystalline penicillin. It has a bilateral rapid progression, and there is a big risk of recurrences. An increased HIV load, then there is a high risk, but it's not always necessary. So if at all you ask me, like, there are so many atypical presentations of syphilis, like how do you characteristically diagnose it? There are few tips. If you have a necrotizing retinitis, diffuse retinitis, not much hemorrhages, and some vitritis, then you probably think you are dealing with the case of ocular syphilis. If you have these placoid choroidal lesions along with retinitis, so then it is syphilis. Syphilis is one thing that can be the presenting feature of HIV. It can also come as panuveitis or endophthalmitis-like picture. This is a young patient who had a panuveitis or endophthalmitis-like picture. Post-vitrectomy, we saw a lesion like this, and then the vitreous sample tested positive for syphilis. So if you have a diffuse retinitis with low CD4 counts, the classical placoid choroidal retinitis in higher CD4 counts, then it is probably syphilis. So syphilis not just mimics infectious uveitis. Sometimes you have a vague vitritis, you might do a FFA, and the fern-like pattern which can mimic Behçet's is also seen in syphilis. So syphilis can mimic non-infectious uveitic entities also. That's why they call it the greatest imitator. But one definite clinical clue are these precipitates. These posterior hyaloid or pre-retinal precipitates. If you see them, then you are probably definitely dealing with a case of a ocular syphilis. The differential diagnosis for a classical placoid lesion is a pneumocystis jirovecii or a pneumocystis carinii choroiditis, which we don't see nowadays. This is because we have this bacterium prophylaxis in all patients with HIV. So this used to be seen in those days before those, but nowadays we don't see. But a placoid lesion like this can be seen in syphilis also. One thing with syphilis is then it really affects all the parts of the body, like all the parts of the eye also. You can actually have a corneal involvement, interstitial keratitis. So anterior segment finding can be a clue. So it primarily affects the stroma. It can have bilateral non-ulcerative corneal opacities. It can have sensory neural deafness, Hutchinson's teeth. You have this famous Hutchinson's triad. The corneal lesions paradoxically are resistant to penicillin, but they are like very well responsive to steroids. Syphilis can also present as granulomatous anterovatus, rarely as granulomatous anterovatus with raised IOP. But then this is a rare diagnosis, so you'll be rarely correct, as they say. A granulomatous scattered capies with raised IOP, then usually you are dealing with probably a viral. So it's very important that since you have an atypical kind of presentation, I'm actually talking quite a lot about syphilis because that's the in thing happening nowadays in HIV and even in non-HIV patients. Syphilis is something that is atypical presentation, so obviously you need to depend on investigations for the diagnosis. There is something called the reverse sequence algorithm. That's the current CDC recommendation, where you do the treponemial test as a screening test followed by a non-treponemial test. The advantage of this is that you can detect early, and treponemial tests are more sensitive to early disease, because non-treponemial tests sometimes can be negative in patients with HIV. So when in doubt, you can actually do an intraocular specimen evaluation. We have actually done TPHA testing from aqueous fluid, and we found some excellent correlation. This is one of the options. You can also have PCR of treponema. The specificity seems to be very good. Sensitivity doesn't seem to be as good as of now. We need to do much more studies to find out whether how good they are, but then that's a good option. So if you're not able to diagnose based on your blood tests alone, then intraocular specimen evaluation of the TPHA or PCR can be an additional supportive evidence. Hearing well, right? Yeah. So when do we do a CSF tap in ocular syphilis? So in general, in Western literature, there has always been an suggestion that like any ocular syphilis, you need to do a CSF tap. But then we don't do it that routinely. A CSF tap you need to do if you have a pan-uveitis. For example, in a patient like this, where you have RPR TPHA positive, where AC tap was negative, and there are neuroimaging findings which were possibly suspicious. In this situation where you have a suspicious neuroimaging finding, and if you have atypical ocular presentation, then probably CSF tap is indicated. In other words, CSF tap in ocular syphilis is not always mandatory. It's not necessary in isolated or confirmed ocular syphilis patients where the signs and symptoms are very typical, and if there are no cranial nerve dysfunction or neurological abnormalities. So if you don't have any cranial nerve dysfunction or any neurological evidence, and if ocular syphilis findings are very confirmatory of those signs and symptoms, then you don't need to do a CSF tap. But then CSF tap is necessary if ocular symptoms are there, but signs are not very confirmatory, and if you have some suspicious neurological signs and symptoms. Again, coming back to imaging clues, if at all you have one posterior infective uveitic condition where imaging can help, then probably it is syphilis. See, like this is a very classical example of the same thing. This is a 30-year-old male who was referred to as optic neuritis. In fact, he was a doctor who had color vision and contrast and visual field defects. The fundus picture actually doesn't pick up too many things. You seem to have some subtle RP alterations here and there. But when you do the fundus autofluorescent picture, this is how it is. There are multiple hyper autofluorescent patches all around. Fundus autofluorescence actually picked up much more lesions than what we actually saw in the fundus. After seeing the autofluorescence, I went back and saw the fundus, and then I realized all these RP alterations. So many times, these are the situations where we would have probably thought normal fundus unless the patient had complained. And another more important thing is the OCT. The SSOCT can have a typical finding in an OCT is the disruption of ellipsoid zone and IZ band with subretinal RP hyperreflective excrescences. This is the classical description in a patient of syphilis. You can have disruption of the outer retina, RP thickening and other things. But then if you have ellipsoid zone irregularities, then probably you are dealing with a case of syphilis. This is the point which I was talking about, and it really gets okay after treatment. This is a classical description of an OCT image in ocular syphilis. So imaging does help. There have been studies that have shown that the retinal miliary lesions They seem to involve the full thickness and may heal with pigmentation, which have been picked up in OCT. So I was talking about ocular syphilis being similar to neurosyphilis and need to be treated like that. So crystalline penicillin is the treatment of choice. Procaine penicillin and benzathine penicillin are alternates. So unless you have some, we in between actually had some scarcity of crystalline penicillin, there was shortage, and that is the time you can think of alternatives. Otherwise, given a choice, CP is the best option. A single dose of benzathine penicillin is not fully effective. That's how many hospitals treat, which is not the right way to go about it, because there is always a risk of neurosyphilis in these patients. Doxycycline and ceftriaxone are other alternatives, equally effective. So how do you monitor it? You need to monitor it by non-treponemal antibody titers instead of the treponemal antibody titers. So a four-fold drop in antibody titer indicates a sufficient response, and you need to see it for about 3 months time, because in HIV patients especially, the titers monitoring is very difficult and may take longer to drop. So you shouldn't jump into conclusion that there is a treatment failure within those 2-3 months period. If clinically it is showing good response and symptomatically and signs are much better, then you can wait up till 2 to 3 months, but then you will have to see for the fourfold drop. If there is a treatment failure, or if you are wondering, then probably you are there is an undiagnosed CSF infection and which you need to treat them immediately. So if at all there is an inflammation, correspondingly you need to treat them with anti-inflammatory therapy in the form of steroids. So it's very important that you differentiate between recurrence and reinfection, so you can wait based on the titers. So just to remind that we are actually talking about opportunistic infections in HIV and eye lesions. So the TB. So we had Soumya talking about bacterial and fungal infections and TB in immunocompetent. In immunocompromised patients, TB may be part of a disseminated disease or rarely an ocular disease alone. This is the classical serpiginous-like presentation which we keep talking about in immunocompetent individuals. So this is a patient of serpiginous-like in a patient with HIV. This was a patient who had good CD4 counts, a low peripheral viral load. So even in a patient of HIV, if his general immunity is better, they can present with serpiginous-like choroiditis. But if their general immunity is poor, then they can present as a choroidal granuloma or a subretinal abscess or a scleral abscess or a panophthalmitis-like picture. Initially, it starts off like a choroiditis. It becomes a larger one as a choroidal granuloma. A granuloma becomes a multibacillary lesion. All these serpiginous-like choroiditis are possibacillary infections. A multibacillary lesion becomes a subretinal abscess, which can break through and become a PANOF. There is no definite correlation with CD4 counts specifically, but this is how it happens. A lower CD4 counts, you may get an abscess. A higher CD4 count, you may get probably a serpiginous-like choroiditis. The interesting thing in ocular TB in HIV is that the ocular course does not coincide with the systemic TB. You treat a patient with systemic TB and ocular TB in a patient with HIV, the systemic TB gets okay, but the ocular course may not still get okay. Then probably the drugs don't cross the blood-brain barrier as fast, so it takes some time. There is always a 10 times greater risk of multi-drug resistant TB in HIV positive patients compared to HIV negative patients. The important thing in HIV patients, one which we need to remember is that the HIV physicians have some guidelines for ART initiation. Any patient with opportunistic infection, based on their CD4 counts, the ART is initiated. There is something called detect, diagnose, and treat. That's what is the NACO guidelines. So you detect a person who is found to be HIV, then start them on ART. Initially, it used to be CD4 counts are more than less than 300, 200, and so on. But nowadays, if you are diagnosed as HIV, then you need to treat. But there are some asterisk marks or small letters, small fonts as they say. One of them is TB. If you have a patient with TB and HIV co-infection, then you follow some guidelines based on the CD4 counts. Because if the patient has very low CD4 counts, then you need to start them on ART right away. If the patient has very good CD4 counts, then you have time at your hands. You can start the ATT first, delay the ART, because there is a risk of paradoxical worsening. So any patient who has TB treatment to be initiated first, followed by ART based on the CD4 counts. So I was talking about paradoxical worsening. So the worsening, if you find a case of TB, you can have worsening in many situations. One obviously can be because of a wrong diagnosis. So if you have a worsening, you need to revisit diagnosis. Probably sometimes it can be because you've not been bold enough in starting adequate anti-inflammatory therapy. Sometimes it can be drug resistance. But the more important thing you need to remember is paradoxical worsening, which happens due to improvement of the host's immune response to the mycobacterial antigens, and is common and can have devastating complications, and is very often if you have ERT starting along with ATT in such patients. So you always defer ERT, wait for the ATT to kick in, reduce the mycobacterial antigen load, and then start ERT. So you're talking about CMV, herpes, toxo, and then what else? TB. But there are some other rare infections like Bartonella, cryptococci. Cryptococci, more often we see in neuro-ophthalmic manifestations. Bartonella neuroretinitis is more often in this Brazil and other areas. There are some high-fine names like disseminated tuberculosis and so many other infections. So we are talking about cryptococci. Cryptococci in India, we don't see cryptococcal choroiditis that often. Cryptococci, we don't see it that often even in our OPD, but then we see it more often in the non-ambulatory patients. The neuro-ophthalmic manifestations are more common in HIV because of cryptococci. Although the commonest systemic association is pulmonary TB, commonest CNS infection is cryptococcal meningitis, and then comes TB meningitis. In the Western data, toxoplasma is the more common neurological infection, while in India it is cryptococci. The CNS infections more often occur when the CD4 counts are very low and more often seen in non-ambulatory patients. Papilledema is the most common presentation. You can even have a PML. This is one of a patient who actually came to us with sudden drop in vision, cortical blindness as a primary manifestation. And investigating for cortical blindness, we diagnosed PML and then had a very short lifespan too. One important thing you need to remember is that you can have disc edema because of benign intracranial hypertension, because of the anemia which can be induced by any of the ART drugs. This is one patient which because of zidovudine, it induces anemia which causes disc edema and intracranial hypertension. So these rod spots or pale centered hemorrhages you need to look for if you have anemic retinopathy like changes with disc edema in a patient. So it is not always that it is an infection in a patient with HIV. If you have disc edema, there can be other causes too. So we are always talking about the posterior segment. A quick infection recap about the anterior segment. Like how popular CMV retinitis is for the posterior segment, as popular it is as popular is herpes zoster ophthalmicus. You can have these large blebs. This is a classical picture, probably this is seen in many of our publications. The more important thing is this Hutchinson's sign. If you have vesicles at the tip of the nose, then you know that the ophthalmic division is going to be affected. HIV is one disease where the herpes zoster needn't be the ophthalmic division, it can even be the maxillary division. So you can have herpes of the posterior segment if the CD4 counts are very low. It can have anterior segment lesions if the CD4 counts are very high. So importantly, even this you need to treat them with systemic valsiclovir. The viral dendritic form stromal keratitis and other viral diseases have already been dealt with by Dr. Padma. So one important thing you need to remember is any middle-aged person with herpes zoster ophthalmicus, you need to suspect HIV. The important aspect about adnexal lesions in HIV is that they can be a sign of a severe systemic immunosuppression. Most of these lesions occur around 250 cells range, and if you have an ocular surface neoplasia, then probably you know that the disease is severe. Molluscum contagiosum is one lesion that can be very large, multiple umbilicated lesions. Important to look at the lash line and the chin strap region, and it can be more severe in children. Kaposi sarcoma is another surface neoplasia, but not often seen in India because the infective human herpes virus 8 is not prevalent in India. Remember that it's not always that you deal with one infection in HIV. You can have a CMV retinitis and a choroidal tubercular or TB subretinal abscess. So this is something which is so clearly demarcated. This is not bilateral herpes zoster ophthalmicus. This is herpes zoster ophthalmicus. This is molluscum. This is an atypical presentation which you don't know what it is. ACTAP showed that it had 2-3 infections in the same patient. So remember that HIV positive patient can have multiple co-infections. So we saw the major chunk, the opportunistic infection. So does HIV cause infections in the eye or lesions in the eye only because of the immunity being low? The answer is no. Rarely HIV itself can cause some lesions in the eye. The more popular one is the HIV retinopathy. So we have learned, we used to be always taught that the HIV retinopathy is an innocuous lesion, but it is no longer so. It can cause visual function defects and it can be an indicator of therapeutic failure, because usually when there are low CD4 counts, HIV retinopathy occurs, and it usually resolves with improvement in CD4 counts. It can be a rare risk factor for retinal vascular occlusions, like in this patient, where you had extensive capillary non-perfusion areas all around. An FFA dye doesn't seem to be crossing beyond any of these points. These are the cortical spots, and that actually causes occlusion. Beyond this, it's not flowing. This patient actually had multiple infarcts in the brain. HIV can cause endothelitis, and this can cause all kinds of ischemic changes all over the body. HIV itself can cause some anterior uveitis or vitritis rarely. So remember that any inflammation in an HIV positive patient, always rule out infection. HIV induced uveitis is a diagnosis of exclusion, but then rarely you can have HIV induced uveitis when you rule out all other causes. We have done a study showing raised RT-PCR HIV copies from the aqueous, but then if in exam, if you are asked whether HIV causes uveitis, the answer is maybe, but first importantly, you need to rule out infectious causes. The important thing to differentiate between HIV-induced uveitis and immune recovery uveitis, which we'll be talking in detail a few minutes later, is that if you have inflammation in a patient with low CD4 counts, and if you don't have any other opportunistic infection proof, then you're probably dealing with HIV-induced uveitis. If you have inflammation in a patient with higher CD4 counts and low viral loads, then and with a past history of an ocular opportunistic infection, then you're probably dealing with immune recovery uveitis. I'm repeating it. If it is an inflammation, low CD4 counts, no opportunistic infection, then it is HIV-induced uveitis. If it is low HIV peripheral viral load, higher CD4 counts and inflammation with past history of ocular OI, then it is immune recovery uveitis. So we were talking about opportunistic infections and HIV itself causing problems in the eye. So I was telling about HIV being a chronic disease. So it seems to have all the chronic disease related problems, like how you have drug related problems. You have, importantly, you need to remember rifabutin induced uveitis. This can be mimicking endophthalmitis as a manifestation of immune recovery uveitis or otherwise. Rifabutin is used to treat atypical mycobacteria in HIV positive patients, can present with pan uveitis or end-of-like picture. The protease inhibitors like nevirapine can present like Stevens-Johnson-like syndrome. So drug-induced uveitis in HIV positive patients should always remember. Cidofovir is one drug where it can cause hypotony. Cidofovir is a drug that you use it for treatment of severe retinitis. An interesting thing that can happen in patients on antiretroviral therapy is signs and symptoms suggestive of night blindness or retinitis pigmentosa like picture. Tifavirenz is one of the ART drugs which can cause retinal toxicity. There are other drugs like ritovidin and few others which can also have similar retinal toxicity or CSR-like response. So a CSR-like response, or if a patient complains of night blindness, don't ignore it in a patient with HIV. It may be ART associated. A change in ART actually reverses them. As they say, heart causes heart problems. Highly active antiretroviral therapy can lead to hyperlipidemia, diabetes, hypertension, and cardiac sequelae. And most importantly, immune recovery uveitis. I've been harping upon this immune recovery uveitis quite many times before. So it is actually a newer ocular inflammation with either controlled or inactive opportunistic infection associated with substantial or clinical immune recovery uveitis in patients with potent immunosuppression. So it means that if a person has had CV retinitis in the past or any ocular opportunistic infection, it means the CD4 count would have been low. So at this point, the body doesn't have significant immunity to hike up an inflammatory response. With heart, the person is showing signs of improvement. This patient is known to be a heart responder. A heart responder showing signs of inflammation is known to have immune recovery inflammatory syndrome called IRIS. An immune recovery inflammatory syndrome happening in the eye is called immune recovery uveitis. So, a patient on heart showing response is a heart responder. A heart responder showing inflammatory response is known to be in immune recovery inflammatory syndrome. And immune recovery inflammatory syndrome in the eye is immune recovery uveitis. So, the immune recovery uveitis can be anything. It can be inflammation related situations like a CME, ERM, or a vitreomacular traction. So, this patient is a severe retinitis patient, resolved well, and CD4 count had an increase and shows inflammatory response. So, this is immune recovery uveitis. So, immune recovery uveitis, we have an unpublished data showing that it is not limited only to CMV retinitis, which was initially described. It can occur post CMV, it can occur post syphilis, toxo, or TB. It can also be recurrent, so you need to have a long follow-up. Whenever there is an episodic CD4 count spurt, there is a possible cause of recurrence that you need to be aware of. And most of the time, an average of about 100 to 150 or about 200 CD4 count increase from the previous count. That's why I was talking about a CD4 nadir count. If there is an increase from a CD4 nadir count of about 150 to 200, then that's a usual commonest range where you get an immune recovery uveitis. So you can use balanced use of steroids. It is safe and helpful. Rarely, systemic steroids may not be as effective. This is not what we actually advocate routinely, but this is one patient where we used intravitreal dexamethasone implant in a patient post-ocular syphilis with recurrent CME due to immune recovery uveitis. You make sure that the infective etiology is resolved, then you can think of using local steroid injections. So we were talking about HIV in adults. So HIV can occur in children due to various reasons. Most common is vertical transmission. Commonest presentation is anti-uveitis. The vernal keratoconjunctivitis is one thing that is most common and can be very severe. Recent studies have shown lesser ocular involvement, but more often vertical transmission is the cause, and VKC is the commonest lesion that you see in children with HIV. So as we keep telling, if HIV uveitis is not enough in patients on ART and with better immunity, we have all chronic disease related problems. So this is if infections and drug related problems are not enough, we have this uveitis. Treating the uveitic patients normally itself is so difficult, and you have HIV and VKH. This is one patient where who had VKH, secondary glaucoma, pan uveitis, and HIV positive. And a kid with JRA, treating any kid with pediatric uveitic kid is a difficult task. This is a systemic JIA patient. You need to plan biologicals, double immunosuppression. But if you have HIV positivity, you need to monitor the CD4 counts, viral load, systemic status. So it's very difficult with ERT. The good thing about ERT is that the general immunity improves, but probably not so good thing is that they start behaving like any other immunocompetent individual and start getting uveitic diseases also. Diabetes is one thing that is quite common in patients with ERT and younger patients with HIV. So is diabetic retinopathy. So we have a study that has shown that. And for completion and to see the future, there have been studies based on mRNA showing which patients will get opportunistic infection HIV and which are prone for immune recovery, uveitis. And early aging changes are seen in HIV. So when you have longer life, then you need longer quality of life also. So it's important that you treat the patients well and make sure that the longer they live, they actually have a better quality of life in patients with HIV. So remember that ERT is working very well. There is good immune reconstitution. There has been decrease in ocular opportunistic infection, but still that's the most common cause of vision loss. So don't miss it. Shouldn't neglect it. CMV retinitis is still there, and syphilis is quite common nowadays. It's re-emerging. One important thing we need to remember that it's not always that they present as it used to present before. It can present differently. The newer lesions can be there and newer manifestations of the older lesions also. More importantly, remember the immune recovery uveitis and the drug-induced lesions. You can have non-infective uveitic entities also in patients who are on ART because they become like any other immunocompetent patients. Intraocular specimen evaluation is very important when you have doubt and it's a good yield. And with better life expectancy, obviously you have all these age-related problems like any other diabetic or diabetic retinopathy patients. Thank you. You are muted.
You're on mute.
Sorry. Thank you, sir. Thank you for this very comprehensive coverage of this extremely important topic. We have a couple of questions, sir. Is there any role of CD4 counts for predicting the ocular manifestations?
Yeah, it used to be actually like it can give a broad idea. The much lower CD4 counts, the posterior segment manifestation like CMV retinitis are more often seen. It is not that they will not be seen with higher counts, but the lower CD4 counts, the risk is much higher.
Okay. So is there anything that has been established, sir, as a range which should be looked out for?
Yeah, anything less than 100 to 150, then obviously you will get CMV retinitis, viral retinitis of the posterior segment. If you have more than 200 to 250, then you get the anterior segment manifestations. TB is one thing that can occur in all the ranges. So one disease, one viral infection that is very sure that can happen with much lower counts is CMV retinitis. Among the non-viral ones, cryptococci is one thing that can occur with low CD4 counts.
Okay, sir. Sir, talking about tuberculosis, can ocular TB present differently in HIV positive patients?
Yeah, actually, that's what I was trying to tell probably. Like then if you, we always keep thinking about surveillance like choroiditis in patients with non-HIV patients. That's what has been the description nowadays. In HIV positive, you can more often present panophthalmitis like pictures, scleral abscesses, subretinal abscesses more often than the typical choroiditis.
Okay. But the management would be the same, AKT with
Management
ERT.
generally ocular TB in immunocompetent results much faster than how ocular TB in HIV patients it takes much longer. So you probably need to be more aggressive. The multi-drug resistant TB is almost about 10 times more common in HIV compared to non-HIV.
Okay. So how do we follow up HIV retinopathy patients who are already on therapy, ART therapy, and what are the investigations which should be done on follow-up visits to monitor their course of disease?
HIV retinopathy as such is HIV retinopathy as such is self-limiting. But then like you need to look at the cortical spots. Sometimes coalesced large cortical spots like they and same granular type of CMV retinitis look little similar. So you can probably miss a CMV retinitis starting point as thinking it is HIV retinopathy. So you can ask for the CD4 counts. If CD4 count are improving, the cortical spot gets okay on its own.
Okay, all right, sir. Okay, so can you give us a precise list of differentials which we should keep in mind as postgraduates when we see a case of an atypical presentation of viral uveitis in AIDS or any immunocompromised patients for that matter?
So basically, anything yellow in the fundus, obviously first thing you think of is retinitis. So like I was looking at like how to differentiate retinitis, choroiditis, and all that. The classical description is that you compare it to the retinal blood vessel. If the retinal blood vessel is seen very well, then you know that it's probably subretinal, it's choroidal. If the retinal blood vessel is partly seen and partly not seen, it is retinochoroidal. If the retinal blood vessel is not seen at all, then it is retinitis. If retina is involved, then it is infection. Okay, so I think like we had a talk sometime telling about the only non-infective condition where you have retinitis is Behçet's. Okay, and which is like transient gets okay. But then in a retinitis, if you have peripheral lesions in everywhere, as postgraduates, pattern recognition wise, if you have peripheral coalescing lesions, then you are thinking of ARN. If you have posterior pole presenting into the posterior pole, then it may be ARN or it can be anything else. If you have retinitis spreading into the posterior pole with lots of hemorrhages, then in an HIV patient especially, then you think of CMV retinitis. A retinitis peripheral, then ARN, retinitis posterior pole or within the equators, with lot of hemorrhages, then probably you're dealing with CMV retinitis. If you have less hemorrhages and then little granular appearance, then again it is CMV retinitis. But non-granular, less hemorrhages, then toxoplasmosis. If you have retinitis with inflammation in HIV patients, then it is toxo or syphilis. Was I fast?
Okay. No, that was all right. I think this would be a very good ready reckoner for postgraduates just before their vivas. All right, sir.
Nowadays,
In
obviously,
interest
probably
of
OCT is a better indicator. Like so, whenever choroidal involvement is there, then probably you're definitely dealing with maybe toxo or syphilis. If it is purely retinal, then it's mostly viral.
all right, sir. Okay. Thank you, sir. In interest of time, we would be ending the session now. Just a couple of things. Our next session would be on the 11th of the month on eye and systemic parasitic infections by none other than Dr. Jyotirmay Biswas. You really want to be here to hear from such a stalwart. And before we end, just a second. Is my slide visible?
Yeah. Just
Yes, ma'am. If we can make it in full screen.
For all our other viewers, the Physical Eye Focus 2025, the biggest national postgraduate education program in ophthalmology, is stated to happen in New Delhi this year from August 10 to 17. Quickly grab your seats. There are very few remaining, and you really don't want to miss this, especially if you are towards the end of your post graduation or just to even know what are the possibilities beyond post graduation after you finish. So grab your seats quickly. Seats are filling really fast. Thank you so much.
Thank you.